A very good morning, friends. Welcome to this very important and the last session of this APO AIOC conference. I hope that we do a good job towards the end of this such a mega event of ours. And I'd like to thank all of you for making this conference so successful. In this particular instruction course, we're going to take you through the perfection in cataract refractive surgery, mainly devoted towards the toric IOL implantation in various ways. And because we know that toric is one of very important corrections which we do in these cases with cataract surgery. And to correct the corneal astigmatism, along with the cataract surgery, nothing better than toric intraocular lenses. Today I have, along with me, Dr. Manpreet Kaur. She's an associate professor in Dr. R.P. Center for Ophthalmic Sciences, AIMS, New Delhi, in cornea, cataract, and refractive surgeries unit. I'm Dr. J.S. Titiyal, the chief instructor of this course. I have my own friend from Singapore, Professor Chi Sun Fek. She's been with us for a very, very long time, with supporting all our courses across the world. Going to be joined by Dr. Namrata Sharma, the Chairman Scientific Committee, Professor in RP Center, and she's recently become the Treasurer of APAO. And my own friend, Dr. D. Ramamurthy, who's replacing Dr. Boris Malugin. He could not make it this time to New Delhi, and they're going to join us very soon. The areas we're going to cover today is how do we assess these patients in terms of pre-op examination, diagnostics, the calculation of corneal power, calculation of intraocular lens power for a different difficult scenarios. Then we'll take you through the basic surgical aspects of toric implantation, some difficult situations, and most importantly, we'll subsequently look into the post-surgical enhancement. There are some cases where you may require to assess these patients and re-titrate your cases, maybe realign these cases if needed. Which are those cases that would be also highlighted in this particular course. We'd like to give you tips, tricks, so that you can outdo your apprehensions in toric implantation. So first of all, I'd like to invite Dr. Manpreet Kaur to take us through the initial phase of preoperative assessment, importantly planning the surgery, selection of IOL power, and actually rule out those difficult cases. Dr. Manpreet Kaur.
A very good morning to all of you. I'll be taking you through the preoperative planning and IOL calculation in premium intraocular lenses. There are no financial disclosures. So the benchmark for standard refractive outcomes after normal eyes after cataract surgery has been that 55% of cases should be within plus minus 0.5 diopters and 85% within plus minus 1 diopters. Now we are in the era of new generation IOLs, the premium IOLs, so as to say multifocal torics, and the focus now has shifted from precise visual acuity to optimal visual quality as well. The patients demand 20 by 20 by 20 and an optimal visual quality free of any dysphotopsia, glare or any aberrations. 80% of the cases should be within plus minus 0.5 diopters and 95% within plus minus 1 diopter. To help achieve this, preoperative planning, IOL part selection and choosing the right IOL is very, very important. So toric intraocular lenses are the procedure of choice to correct corneal astigmatism of 1 diopters or more. When you are implanting a multifocal toric, the threshold is much lower to 0.5 to 0.75 diopters as the patients do not tolerate any residual cylinder. Preoperatively, IOL power and axis and ocular examination for surface, angle alpha and higher order aberrations should be performed. Intraoperatively, we will in the subsequent talks take you through precise toric IOL alignment and challenging case scenarios, and postoperatively of course tackling misalignment and the enhancement procedures. So patient selection, comprehensive ocular examination is of course a must to rule out any comorbidities that may interfere with postoperative outcomes. So who are the poor candidates for toric or premium toric IOLs? Any irregular astigmatism, corneal scars or ectasia. A poor ocular surface is a relative contraindication. If you can optimize it, treat it optimally, then you may still go ahead with a premium intraocular lens. However, in persistent limbal stem cell deficiencies, ocular surface disorders, you should avoid premium intraocular lenses. Prior ocular surgeries such as glaucoma or vitreoretinal procedures, poor pupillary dilatation, posterior capsular dehiscence, zonular instability, basically the ocular comorbidities affecting the retina, the visual axis, they are relative contraindications for implanting a premium intraocular lens. So the corneal curvature and IOL has to be assessed preoperatively. Angle alpha, the IOS tends to center on the limbal center and not over the visual axis, and a large angle alpha combined with a multifocal or toric gives compromised vision, leading to potential complaints such as blur, double vision, halos, etc. So you should avoid premium intraocular lenses in such cases. Corneal internal and total higher order aberrations should be assessed using ray tracing aberrometry, and excessive higher order corneal aberrations will compromise with the visual quality in the postoperative period, and you should counsel the patient appropriately. Ocular surface, the tear film stability, tear secretion, osmolarity, staining should be performed. Lipid layer thickness and tear meniscus height can now be observed non-invasively, and a mebography should be done to rule out any meibomian gland dysfunction. So we have now new devices at our disposal, and it should be a part of your regular routine preoperative workup when evaluating for premium IOLs. Coming to the IOL power calculation, so it has two aspects. One is capturing the accurate biometry, second is the formula that you use. So advances in biometry have led to precise IOL power calculation for axial length. Of course, contact ultrasound biometry is where we started from contact applanation, then we went to immersion. Now most of us rely on non-contact optical biometry, which has a higher accuracy of plus minus 0.02 millimeter as compared to a plus minus 0.1 with the contact ultrasound biometry. Keratometry, you have to determine the power as well as the axis of a toric IOL. Various instruments based on different principles may be used, such as manual and automated keratometers, Placido-based topographers, slit scanning systems, stream flux systems, aberrometry, and OCT-based systems. More important than which device you invest in is to take multiple measurements and ensure that they are reliable and repeatable. Employ at least two separate devices based on different principles. This will lead to an enhanced accuracy of keratometry estimation. Cases with similar axes on different devices are good candidates for toric IOL implantation. If you have variability in both the axis and the magnitude of toric IOL on different devices, do rule out any comorbidity, and visual outcomes in these cases may not be satisfactory. Now coming to the posterior corneal curvature. So anterior corneal curvature we know acts as a plus lens. This is what is measured by the traditional keratometry devices, and it may be with the rule, against the rule, or oblique, shifts with age from with the rule to against the rule. Posterior cornea acts as a minus lens, is generally steeper in the vertical axis and causes against the rule astigmatism. It remains stable with time to the magnitude of 0.3 to 0.5 diopters and must be taken into account while calculating for premium intraocular lenses. Because if you are not taking into account the posterior corneal curvature, you are going to end up with an overcorrection of with the rule astigmatism to the tune of 1.38 times and an undercorrection of against the rule astigmatism to the tune of 0.65 times. So how do you measure the posterior corneal curvature? You can either measure it directly on the newer devices, stream plug based, Purkinje images based devices, slit scanning devices, or OCT based biometers, or there are prediction formulae that just take into account the value of 0.3 to 0.5 diopters in their IOL calculation formulae. So you have nomograms for that. The Baylor one is quite popular, Abulafia-Koch, and online calculators can do it for you easily, the Barrett online toric calculators and other online calculators. So just an overview of the investigative modalities to assess preoperative keratometry. If you see The newer optical biometers and devices used for IL-PAR calculation all measure posterior corneal curvature either directly or incorporate it in their formula. So they are based on various technologies, as I just elucidated earlier, on swept source OCT, Barrett, digital recreation of the posterior corneal curvature, dual channel stream plug, or Purkinje imaging technology. So an ideal IL-PAR calculation formula should give you the magnitude of PAR, toricity and axis, take into account the surgically induced astigmatism and posterior corneal curvature, and also account for the effective lens position. So the newer generation formula are to be preferred. We have moved beyond the SRK formula. Virgin's formulas, the newer ones are Holiday, SRKT, Barrett, Hagees, Hopper Q. We have artificial intelligence in the mix. It is soon going to replace a lot of formulas that we have been relying on. Hill RBF, Pearl DGS, Oculix, and then the ray tracing aberrometry based formula such as the Olsen formula, which accounts for asphericity and aberrations of the cornea and IOL. Surgically induced astigmatism, various online tools are present. On an average, it's 0.2 to 0.3 diopters with the now microincisional cataract surgeries of 2.2 incision. Effective lens position, why is it important? It's still the holy grail of IL-PAR calculation. When we look at the axial length and keratometry, we are almost there in terms of precision. We are very reliable with the newer devices. Effective lens position is what is still giving us a variability in not reaching 100% of cases within plus minus 0.5 diopters or within plus minus 1 diopters, because however much you may try to predict with a host of variables, 6 variables, 7 variables, still the accurate effective lens position is not being 100% accurately predicted. 1 millimeter error in ELP can cause a 0.1 diopter error per diopter of cylinder in the IL plane, and use of a single conversion factor for converting the cylindrical PAR from IL plane to the corneal plane without considering the anterior chamber depth and pachymetry are potential sources of error. Now again, this ACD and ELP are not going to be the same in the normal axial lengths and in extremes of axial lengths, and this may result in erroneous calculations. So posterior corneal astigmatism, various devices do measure them, as we just saw earlier, and the highest precision as found in this study by Hoffman et al. Was observed by combining the keratometry and OCT based data. This is just an example of a Baylor nomogram in which you leave the patients with slight with the rule astigmatism to account for the shift from with the rule to against the rule that occurs with time with aging. So if you look at these nomograms that Baylor has given, for with the rule astigmatism, your threshold is much higher, till 1.69 you can go without a toric. For against the rule, 0.4 or more, you should implant a toric intraocular lens. Barrett toric calculator takes into account both the effective lens position and posterior corneal astigmatism, and is said to have better predictability than the Baylor nomogram as well as the Holiday and Alcon toric calculators. Online calculators have since quite some time now been revised to incorporate corrections for posterior corneal curvature. So there is no excuse as of now to just rely on the anterior corneal curvature measurements. You do have to take into account the posterior corneal astigmatism if you are doing premium IL practice. It's not necessary to accurately measure using the high-end devices. Pereira et al. Observed that directly evaluating the total corneal power is not superior to estimating it using formula and nomograms. You just don't have to forget about it. You have to take it into account. Whichever method you use, eventually you will fine tune it to your practice. Intraoperative wavefront aberrometry is increasingly being used to estimate the toricile power and axis of placement. It's very, very useful in challenging cases such as the post-LASIK cases, in which its accuracy is more than other formulas. And a retrospective analysis observed that the mean prediction error with ORA was only 0.43 plus minus 0.33 in post-LASIK cases undergoing toric IL, and it was much more accurate than the standard SRKT and online ASCRS calculator formulas. So just to summarize, premium IS patient expects premium refractive outcomes. Axial length optical method should be preferred, keratometry, more than one device based on different principles, repeatability of axis is important. ILPAP formula, use the newer generation ones and do take into account the posterior corneal curvature. What the future holds is artificial intelligence, personalization of ILPAP calculation formulae, more effective prediction of ELP. Thank you for a patient hearing. We now have Professor Tityal who will take us through the methods of alignment of toric intraocular lenses, manual as well as image guided.
Thank you, Dr. Manpreet, for a good initiation into this instruction course. I think important thing is how to assess your patient, which is very, very important. No financial disclosure from this particular presentation. Let me summarize what Dr. Manpreet talked about. So we said when to implant toric IOL. I think regular corneal astigmatism, very important, because if you have irregular astigmatism, toric IOL may not work. Anything more than one diopter in a normal monofocal lens has to be corrected. If you're going for a multifocal IOLs, trifocal IOLs, the new generation monofocal plus or EDOF lenses, even up to 0.75 diopters you may have to correct. The second important issue she discussed was how to determine the magnitude, axis and cylinder in the cornea. The devices measuring total corneal keratometry, that is anterior and posterior curvature, is good. Multiple readings on more than one device has to be taken so that you have a more accuracy. Look into a axis match. Power may be little plus minus, but if axis is matching, that's a good regular cornea. And in terms of devices, if you have OCT-based systems, that will be better. Formula-wise, he told us that take into account posterior corneal astigmatism. Any formula which takes into this, surgically induced astigmatism, the anterior chamber depth and effective lens position. Apart from that, there are various nomograms, formulas, online calculators which is going to help you to get a best formula for your patients. Ultimately, we are looking for a customization of each patient based on these initial examination and the investigations. Surgery may be effective. There's nothing different in surgery as we do for our routine cases. The only thing different in the cases with toric IOL is you have to measure the astigmatism axis, that is the steeper axis, mark the axis on the eye by various means, place the intraocular lens in such a way it matches the axis which you have marked onto the cornea, or you have automated devices which tells you that where exactly lens has to be positioned. Most often, these toric marks are there in an optic-haptic junction. That gives a clear orientation of your lens. And most importantly, avoiding the misalignment on the table or avoiding the rotation happening in the post-op period. So these are four important things whenever we are doing toric IOL implantation in these cases. What are the various ways to mark the axis onto the cornea and alignment also? So you have manual marking, which many people use, and if you have access to image-guided systems, which can be Callisto with the JAIS system or Varion, the Alcon system, that provides a very simple orientation during the surgery, and it also takes care of all deviation which can happen, because most often you are measuring these patients' sitting position, and when patient lies on an operation table, you can have little bit of intorsion coming in these cases also. The other way is intraop abnormality related analysis, that is halos and aura. If you have access to that, that can also add into your surgical accuracy in these cases also. So what are the various things we're looking for manual marking? You can have a freehand marking, you can use slit lamp markings, and you have a marking devices. People have devised various marking devices which may help you in actually dividing your initial representation of marking these cases also. These are various instruments which can give you access to how to do it. So you have a bubble marker. This bubble gives you orientation. It is parallel to your orientation of where you're going to place it. You can asycotoric marker, or you have a pendular marker which is going to give you more ideas. So this gives you a marking onto the cornea. You have two sharp edges there. Then you have other markers which are based on a straight lamp also, which gives you actual marking onto the axis of IOL implantation. So you have two types of marking. One is a reference marking. Based on that, you're going to mark the axis of the orientation, or you can directly mark the axis by straight line methods in these cases also. This is what we should do early where we didn't have the automated system, because it is not only the 9 o'clock which is important, it is 6 o'clock is also important to mark, so that when you put the axis marker, you have perfect orientations. So to have a 6 o'clock marking for, you can use any pendular device to give you a 6 o'clock, then mark a 3 orientation also. These are various studies comparing various marking techniques. In fact, all these marking techniques are equally good if they've been done by experienced person. So you have to get experience how to mark accurately in these patients and get effective marking onto the corneal or limbal surface also. I think if you look into various marking devices, you're going to compare them. But if you have manual marking and image-guided system, definitely you will have advantage of image-guided system for more accuracy and better outcome in these cases also. So these are various image-guiding systems which are available with us. I talked about other devices, like you have OTAS, Harkstite's system, you have iTrace system which can give you Varion, Callisto, TrueGuide. These are various devices. If you have, you can acquire them. Definitely going to help you. And Aura, which is also a good incorporation into your system. It is a system which can be put onto the microscope optics, and you can measure the wavefront refraction after you make a aphakic refraction in these patients. That gives a lot of guidelines. I'll show you that also. So these are important 5 steps of surgery. So first, we have to have a better IOL selection. That means material which is better oriented. Haptic designs are very important now. We have realized the designs which are better co-opted with a capsular bag that has a lesser rotation in a post-op period. And the axis has to be perfect. Place your IOL in such a way where it doesn't rotate. You remove the viscoelastic completely if you are using a viscoelastic for an IOL insertion, and align in a proper way also. Just to show you one represented video which is based on a image-guided system. These are very, very important tips. So this is what incision mark is there. This is important because every time when you are doing a toric IOL surgery, if you are in the same size incision, your SI is going to be universally same. So you're not going to modify them. Whenever you're looking toric IOL implantation, don't shift your incision as per the steeper axis. We are managing the toricity by intraocular lens, not by the incision modification. So always remain with the main side, main incision every time, so that you have a nice calculated SIA, which is quite less if you are 2.2. So this is my axis orientation, and this is a rexis orientation. You can see 2 marks are here. These 2 circles are 5 and 5.2 for me. So I'll be going in between those, so that my rexis is around 5 millimeter, which is a very good rexis size. Because it is very important to have a good rexis for an effective lens position subsequently also. The nucleus emulsification is as you do. It should be done in such a way it doesn't compromise your posterior corneal, capsule or anterior corneal endothelium such. After we implant the lens, as I said, it's very important to take out the viscoelastic from underneath the IOL, because there is the possibility you might retain some viscoelastic, and that may be cause for rotation in the post-op period. Then also remove the viscoelastic thoroughly from over the anterior surface also. If you want, you can do a little bit of anterior polishing of the anterior capsule. The oriental lens, these 3 markings are very nice, and always make sure your 3 dots matches these 3 lines also. If I show you in a magnified position, you'll see that these 3 marks are right up to the central area also. This is very important to know that they are actually oriented correctly. Then subsequently you can highlight the wound also. So what we have learned here, you do a good rexis, do a good emulsification, implant a lens in a proper axis. Most importantly, remove the viscoelastic thoroughly from both underneath the lens and over the lens, and place the lens accurately also. So this is what you're going to get outcome in the post-op period. You can say only 1 degree rotation from the axis which I had to implant, and there is a 0 diopter change required in these cases also. Day 1, no rotation required, a good visual acuity outcome in these cases also. Little trick on these open loop haptic lenses. They are very difficult to be rotated, anti-clockwise. They are easy to rotate clockwise. You can't rotate backwards. So if you shift from a little bit to, if you shift towards the clockwise, then you can't rotate back. You have to rotate entire 180 degrees. So therefore, our advice is to leave the lens little anti-clockwise when you're hydrating the wound, so that lens, even if shifts, you can rotate in a proper position also. You can see here, I am correctly oriented now, matching the center line. I thought I'll do a good hydration here. During the hydration, lens shifted clockwise. You can see at least 7 degrees shift to clockwise. Now I'll have to rotate the lens entirely 180 degrees to come to that area also. So that is a small trick. Leave your lens little anti-clockwise so that you have a chance to rotate if there's a shift happening in these cases also. That makes easy access to these cases also. This is so how manual marking should be done. If you are using a manual marking also, you need to have a 6 o'clock, 3, 9 o'clock marking so that this orientation becomes more stable in terms there's no intorsional effect. And marking should be very sharp and effective. If you have fuzzy marking, that also will give a little bad orientation also. These sharp markings are very good to avoid post-op, deficiency happening in these cases also. Other area is image guided, along with the aura system in these cases. So this is a variant guided surgery being done. I have done the Rexis, and subsequently I'll complete the phaco. Once we complete the phaco, fill up the chamber with viscoelastic. Now we'll take the optic reflection. That gives you a new calculation of IOL power as well as axis. Accordingly, choose the lens, implant the lens, and place it according to the axis given by the aura. Hydrate the wound. Again, take a readings. It takes 40 readings immediately and tells you on the table that no rotation required for this patient and what will be the residual cylinder also. So that is a very effective way to manage, especially cases of post-refractive surgery where your astigmatism may be difficult to sometimes measure in a pre-op condition. This is a very good way to look into these cases also. So once you have so many various ways to handle, manual versus automated, this is a study we did to compare, is really the automated system going to give you a difference in terms of outcome? So this comparative study where we looked into a bubble marking technique in a manual and image guided by Jai's Callisto system, we realized if you do an image guided system, it gives you much more closer to the axis of desired, and it is significantly better than a manual way, and your outcomes, visual quality outcomes are also better with these devices also. So there is a definite improvement in the quality of vision, though the final acuity may be similar sometimes, but if you look into contrast, the MTF is better with the image guided systems access. Some of the femtosecond laser devices also are with, you can make a little bit of a nudge into the capsular axis area, and that is orientation of lens. And it matches correctly with the orientation of image guided system also, and it can give you a much more better orientation. To summarize the surgical aspects, I think you can look into manual methods, which I said pendulum may be the best way to mark your axis, reference axis. In these cases, image-guided systems are better in terms of getting better visual quality. And intraoperability, if you have, that's going to add into your accuracy, not only in putting lens in a proper axis, also calculating the IOL power on the table. Only thing you need to have an inventory of lenses with you, 2 or 3, so that you have accurate lenses in these cases also. That is how you're going to achieve good results from these patients. Thank you for your kind listening.
Great talk, Dr. Titial. Just one query. The sense that image-guided system, the Callisto, the Varion has come to stay. But intraoperative aberrometry, there was a lot of interest initially, but now somehow interest is waning. People who even have it, not using it much. What's your take on this?
The only thing I think, the difficulty is 2 or 3 things difficulties are there. One is the extra cost to the institution or to the surgery-wise. It is mounted onto a microscope, and sometimes the space, surgical space goes little less in these cases, and it takes a lot of time. Because once you do a surgery, then you have to have an aphakic situation, then it takes a refraction, then calculates the IOL power, then you need to have an inventory of lenses if you have to modify them. But if you look at the results in terms of literature-wise, the outcomes are almost similar. If you compare image-guided versus the aura, the result has not changed much. So that may be one reason that it's not become popular. Other thing is sometimes maintaining the corneal thoracic curvature, intraocular pressure, they're all little bit challenging sometimes, and it is not applicable to all group of patients. Like you can't do it in a pediatric patient where it may be most useful. So these are situations little challenging.
We now move on to the next talk by Dr. Ramamurthy, tackling toric IL misalignment.
Thank you, Professor Titial, for including me in this nice course. The topic given to me is management of toric IOL misalignment. I'm going to be talking about factors affecting toric IOL alignment, the postoperative assessment, and in case this misaligned, how do you exactly realign? So to leverage the full potential of a toric intraocular lens, accurate alignment in the capsular bag is extremely critical, and any significant deviation from the intended axis deteriorates the visual function. It's well established that 1 degree of toric misalignment causes about a 3.3% reduction in the astigmatic correction, and rotation beyond 5 degrees is considered clinically relevant, and rotation of anything beyond 10 degrees needs surgical intervention. And the greater the amount of toricity in the lens, say 4 diopters or 4.5 diopters in the lens, the greater the propensity for misalignment to cause a residual astigmatism and need for realigning them. And one of the things that we need to understand that there is the greatest misalignment occurs during the first hour after surgery. And if you get the lens rightly positioned in the immediate post-operative period, very often in the after the first day, the post-operative rotation is less than 1%. This is one of the reasons that we keep our patients patched immediately after the toric IOL patients, even if they're done a topical anesthesia, patch for about an hour's time, keep them in the ward, and then see them after a couple of hours and then send them home. And we have not done a scientific study, but we feel that this might be one factors to lessen the chance of misalignment. And as far as the intraocular lens itself is concerned, there are modifications that have happened. Between the Technis Toric 1 and the Toric 2, all the features are exactly the same, except for the fact that in the Toric 2, the the frosted and squared haptics of the haptics have been changed. Essentially, what was done was when the entire optics and the haptics was polished, they just introduced some sleeves onto the haptics so that the haptics did not get polished. This was just a modification of the manufacturing process, and because they were left frosted, there's greater friction between the equatorial region of the capsular bag and the haptics, because of which the propensity for this to misalign is reduced in the immediate post-operative period, that is soon after the lens is placed in the eye. This also has a collateral advantage in the sense all of us know that the hydrophilic lenses, the haptic and the haptic, have the less amount of propensity to stick to each other. When in hydrophobic, there is greater tendency to stick, and sometimes we spend some time separating the haptics from the optics. Once you have the frosted haptics, the tendency for the haptics to stick onto the optics is also reduced, and they tend to unfold and go into the cornice of the equator quite faster. And because of this addition, again the tendency to shift might be reduced. As you can see over here, just a quick video to show you the frosted haptics and the intraocular lens being implanted, and you can see that these are roughened up, and I think slowly many companies are moving in this direction. And once you have this roughened edges and also squared edges, then the propensity for the lenses to rotate in the post-operative period is significantly reduced. And with these compared to the Toric 1, Technis Toric 1, the Toric 2, the 84% of the eyes were within 0.5 diopters of intended cylinder, and 98.5% of the eyes within 1 diopter of intended cylinder. And this, even more importantly, even in the larger eyes, like highly myopic eyes with even a 30 diopter lens, this stability of these lenses is well established, and axial rotation usually does not occur. It's not just the Technis toric, but there are other platforms, even some Indian lenses like the iCrill, the fine vision lenses, and the Vivinex toric. Actually, the Vivinex was one of the first lenses to come up with the Hoya platform, to come up with a rough and haptics. You can again see this rough and haptic. So whenever, as far as the stability of toricity is concerned, apart from other features, one aspect you could take into consideration is that if the haptics are roughened up, there is greater stability. Then the design of the haptics itself, you have the AcrySoft toric. Actually, the reason the J&J went ahead and roughened up its haptics was it was established that their lenses, toric lenses, had almost 3 times propensity to rotate compared to the AcrySoft. And the AcrySoft, though the haptics are not roughened up, the design of the haptic, the stable force haptics, where it functions something like a finger. So depending upon the size of the capsular bag, there is a propensity for it to unfold and be adherent to the capsular fornices. And the stickiness of the IOL material also provides further stability. We ourselves conducted a small study in the year 2022 to 2023. The AcrySoft IQ toric, 615 implants, Hoya Vivinex toric 265, and Technis toric 2, 417. And what we found was that the amount of rotation was about 2% in the case of AcrySoft toric, and cases which required a re-rotation in the post-operative period, while in Technis toric 2 it was 0. This is significantly improved compared to our experience with the Technis toric 1 itself. This is just to show you a published literature. From 5.7% in Technis toric 1, it came down to 0.6%. Almost a 10 times reduction, simply because of the only change was the roughening of the haptics. In the case of an AcrySoft toric, it's about 1/3, and this was one of the reasons why this modification of the haptics did happen. So in summary, as far as the design of the intraocular lenses is concerned, the rotation occurs most often within the first hour of implantation, and frosted haptics mitigates this because of greater friction, and design of the IOL also adds to the stability, as in the case of an AcrySoft IQ. The most sticky hydrophobic material also lessens the chance of rotation. This is just a toric intraocular lens being implanted with a digital overlay. I most often implant my lenses under just under irrigation, do not use viscoelastic. But when you have a screw type injector, you have to use a viscoelastic in this case. And this is just as Professor Chityal mentioned, you make sure that you have to rotate these lenses just in the clockwise manner. And once you have done that, you even after removing the speculum, please ensure that there is no shallowing of the AC and rotation of the intraocular lens. And these are some points during surgery that you need to keep in mind. A little longer incision so that they close more securely. Avoid overinflating, because if there is significant amount of saline around and behind the lens, just like viscoelastic, again the lens can rotate. Ensure complete visco removal. If possible, do a hydroimplantation of these lenses. At the end of the surgery, nudge the intraocular lens onto the posterior capsule so it sticks to it. Slightly smaller rexes, well-rounded rexes, so that at least there is a 0.5 millimeter regular overlap of the rexes onto the optics of the lens. Ensure that the position of the lens is stable even after the speculum is off. And if there is residual, then rotate after about 3 weeks. Of course, astigmatismfix.com as well as Barrett RX formula that can be used in case you have experienced a rotation of these lenses. Usually, unless it's a gross rotation which has been noted on the first post-operative day itself, I wait for a couple of weeks of time for the lens to, the capsule to fibrose a bit before taking up these patients for rotation. My favorite formula for this is the Barrett RX formula, which is available on the web, both at the ASCRS and APSRS websites. This tells you what exactly is going to work, whether it's IOL rotation, IOL exchange, or piggyback lenses that is needed. Look at a situation like this. This is actually what we encountered in one of our cases. 24 diopter T4 intraocular lens being implanted, and the residual error was +1 with -2.5 diopters. One of the most important things you need to understand is that rotation of these lenses is going to help only if the spherical equivalent of the residual error is almost 0. Here, the spherical equivalent of 2.5 diopters of cylinder is 1.25, which corresponds to almost the spherical error that is there. If it is just minus 2 diopters of cylinder or just a plus 1.5 diopters of sphere, the rotation of the lens is not going to help, simply because by rotating the lens, you are not adding or taking away any power, but you are just realigning the power. So essentially, you have to understand that rotation will help only when the spherical equivalent is almost zero. In case there is this is shown for this particular lens itself, but in case it was not zero, I would go ahead and exchange the lens, and this formula will tell you what exactly should be the power of the intraocular lens that needs to go in. And in case the patient has presented to you after say 5-6 years of the initial surgery being done, and the capsule has completely fused down, wants the historicity to be addressed, then you can use this IL exchange, the same formula, to tell you what should be the power of the piggyback lens that needs to go in. Now this is just to show you. So I think with this formula I am able to address all the concerns. As far as coming to some real life scenarios is concerned, case 1, most importantly I always emphasize, whether it's cataract surgery or refractive surgery, ask my optometrist not to go after those small powers if the patient is happy. It was a toric monofocal, so obviously there was a need for a presbyopic correction. But the patient has 6 by 7.5 diopters, and this was the refraction that was there. Patient was not complaining, and anyway I had to give glasses to that patient, so I just went ahead and prescribed the glasses with this. But most often he could function without glasses. So really don't go after that small cylinders if the patient doesn't have a problem. And in this particular case, even though the residual cylinder was just about minus 0.75 in 130 degrees, the patient was extremely unhappy because she had just about a 615 uncorrected visual acuity. And then we suggested that we could do the right eye surgery and then take up the left eye for rotation if she was not so comfortable. But then she insisted on the left eye being taken care of. As I said, it's simple astigmatism. We went ahead and did a PRK for this particular patient, and it worked out very well. And this was a case of a resume which I had implanted way back in 2003. She underwent bilaterally for a development cataract at the age of 10. YAG capsulotomy was done in 2015 for a PCO in one eye. And she had settled down in the US, and at the age of around 31, she came back regularly. She used to follow up with us during our visits. She had about minus 2 diopters of astigmatism left over, as you can see. And at this point of time, she wanted that to be addressed. So the surgery had been done almost 20 years back. And essentially what we are doing here is to put a piggyback toric intraocular lens in place, so that it was just a minor amount of astigmatism, but because the cornea was not appropriate, the TBI was almost 1 in both the eyes, we could not do a laser vision correction. So this is a toric piggyback lens that's being implanted to take care of the residual astigmatism. We did not consider rotation or anything because this surgery had been done almost 20 years back, and it would have been very difficult to rotate this lens. And just in case this was the postoperative outcome in this patient, we implanted the lens in both eyes 2 days apart. It was a very comfortable patient. And when you have a situation like this, is what was alluding to, 1.5 diopters with minus 2 diopters a cylinder, and the uncorrected visual acuity is 6 by 12, obviously a very dissatisfied patient, and she had received I think a continuous range of vision toric intraocular lens. This is what you see over here. So basically there was a significant misalignment, and this is just to show you that the Barrett RX formula and the astigmatismfix.com almost function equally well in both these cases. Both of them show that there should be almost a 33-degree misalignment which has occurred, and obviously this needs to be taken care of, and this is exactly what we do. Basically you can see the lens head should have been in this axis, but it is over here. We had waited for about 3 weeks, and you can see some amount of fibrosis, the capsule that's occurring, but still though it's a hydrophobic acrylic material, it has not got adherent. So I do not use any viscoelastic, but I just go in with a irrigation cannula, then with just using a Sinskey hook, separate out the capsular adhesion from the optics of the lens. Unfortunately, what's needed is just a little amount of with the rule clockwise rotation, and this is what is being done gently, and with the digital overlay in place, you can ensure that the alignment is accurate as you want, and this was the final position. So basically toric intraocular lenses have come to stay, and I think many practices, almost 60 to 70% of our lenses are toric lenses, and once you understand these lenses completely and deal with any problem that arise out of them, you can give the optimal results. Thank you so much for your kind attention.
Thank you, Dr. Ramamurthy. Just one question. Sometimes, what we see, if you look at toric alignment, lens alignment, 3 dots are matching exactly onto the, your marker. Other 3 dots are not matching. Any trick in that?
Yeah, we do see that, and more often it's all 3 dots are matching, but they're not exactly in line with where you want it to be. As far as it's parallel to that line, then I do not mind. There are 2 boundaries that are set apart, and if it is within that, it's okay. And sometimes, especially with the Indian toric, sometimes I experience that the toricity does not exactly align. But I try my best, but if it doesn't, if it is within those boundaries that are there, I leave them behind. I think it's also because of maybe inappropriate marking or slight misalignment between the capsular back size and the overall cornea.
Okay, thank you, Dr. Ramamurthy. Now we go on to the next talk, that is by Dr. Chi Sun-Fek. She's going to talk about putting this premium IOLs in challenging situations.
Thank you. So good afternoon, everyone. I thank Dr. Titiel for inviting me to participate in this very important course. So I'm going to talk about, the situation where inadvertently you have a complication, and what do we then do? Now, I'm going to start with a case which is a little controversial, right? It's a 64-year-old male who's a plano presbyope with cataract in both eyes, but worse in one than the other. And looking at how he runs his daily activities, he really wants to have a trifocal lens in that right eye. So let's have a look at the clinical examination. So the eye looks normal from topography, from of the OCT, of the optic nerve, of the macula, everything looks normal. But when you look at the cataract, what do we see? We see a polar bear there. And what's worse, all right, the polar bear has bitten through this posterior capsule. So am I going to be able to fulfill his wishes? I told him, well, we'll try our best. When we look at the anterior segment OCT, which Dr. Titiel, Dr. Namrata Sharma have actually taught us, actually it's very important to do this test, and you will see the type of polar cataract you have here in this right eye. All right, it's already ruptured, for sure. The posterior capsule is discontinuous there. So what lens am I going to offer him? So I'm just going to fast forward through this, because it's just how I do a polar cataract that's already pre-ruptured, putting some viscoelastic there under the anterior capsule, and then doing the phaco in my standard polar cataract technique. Okay, I'm going to just fast forward through this. So I just do a cross chop, and then towards the end, we have this epinuclear plate that's still intact over the polar opacity to protect the defect. Okay, so these are the last 2 fragments. I've done it without rotation, and here comes the epinuclear plate that has been protecting us from the vitreous phase. And dispersive viscoelastic goes into the bag before I remove the rest of the cortex. And still the anterior vitreous phase is not disrupted, so we're still being able to handle this case with wet aspiration of the cortex. And once we've done that, what lens shall we put in? So how many of you would go ahead with a trifocal lens? In this case, it's non-toric. How many would go ahead with that? 1 hand, 2 hands, a few hands. Okay, definitely not the majority. Okay,
But,
so
Dr. Chi, the problem would be if this is the first case and I put a trifocal lens in this, I never know what will happen to the other eye, which is also posterior polar. Then
Okay, exactly. I'm going to show you the other eye after this. Okay, this is the fun part. So I thought, okay, I'll try and grant you your wish. This is your dominant eye. You want this in, all right. I would have preferred this to be the non-dominant eye. But because, there's no loss of capsule, the support is still there, I can do it very simply. And so he had a good outcome for this eye. I told him, don't come back to me, but he returns 2 months later, and he says, now I want my left eye done, and I want the same lens. And this one is actually planned for a trifocal toric lens at 90 degrees, and if the capsule breaks, it's my fault, okay? So we bring the patient to surgery again, and at the end, the capsule breaks, right? Because if one side it breaks, it's very highly likely that the other side would be quite similar. But fortunately, the direction in which it breaks is in my favor, okay? And I put this into the anterior chamber, as you can see. I'm rotating this toric lens to the axis that I intend at 90 degrees. And I'm just gently dropping this RL, haptic by haptic, into the capsular bag. So this is a very safe way of implanting it exactly at the axis that you want it to be. All right, so this happens to be 90 degrees, and it was in my favor, and this eye also did very well. Let's have a look at this case now. This is a lawyer who wants to go to court the next day, and I had a small fragment that dropped, and you saw that rip in the posterior capsule. And my retina colleague was just about to walk out. I said, just wait, I have to put in this lens for him. So I said, I'm going to try something new. And you can see here I've written that 2010, that's how long ago it was, okay? And so I think this is probably one of the few cases that were being done on toric lenses that had a PCR like this with a drop fragment. I looked at the alignment, no, it wasn't good, so I redid it, but you can see I'm using lens grasping forceps that don't permanently mark, all right, on the optic. And once I am happy with the correct alignment, all right, which are not these marks here, I actually checked it with the toric ring, then I actually leave it there and optic capture it, okay? So even after optic capture, you can uncapture it, right, by holding it with the forceps and adjusting its position to a deeper plane, and then you can rotate and then lift it forward again. Okay, so in the case of anterior capsule rips, and we have premium lenses, right? So this is a case here, and you can see that rip right across there. So what are we going to do? So this patient here, you can see, unfortunately, my toric axis is exactly there. But I felt that it was safe. I think this is controversial. I had adequate follow-up of this patient, and that lens, fortunately, has not rotated. I do think it does depend on your haptic design, but I have used the Alcon platform for many years in my practice, and I did not see any movement even with any capsule change. You want to comment on this, Dr. Titiel or Ramamurthy?
No, I think, these lenses are very stable, but now I think with the roughening up of the haptics with some of the other lenses that I showed, the stability is even better.
Yes, agree. I think the Technics platform, it's so difficult to even shift it when I want to move it 1 degree. Yeah, so anyway, this is how I got away with this eye, all right? It ripped right across there with a femtocapsulotomy, but it was fortunate this patient did well. Okay, now this is a little more challenging, and my fellow called me. She was doing this case, and she told me her rexus had run out. So here I am, the pupil is coming down now, the lens is not in. I'm doing a posterior capsule rexus because that's the only thing I think I can use to help to stabilize this lens. Okay? So soon we'll be able to see what's happening behind. She just described it to me. I believed her. So I've actually placed the lens again in the anterior chamber. And I'm going to rotate it to the axis. You can see here, 9 degrees. And I'm just going to put it behind. All right? Now, where is the sulcus? Where is the bag? The pupil is so small. So at this stage, I said, okay, it's in a reasonable position. I'm going to do optic capture first. And then after this, I'm just going to check on it, all right? So actually, I should have put in iris hooks first because really I just believed her. And I said, I'm going to capture it here. But I need to be sure that the haptics of this lens are actually in whatever bag is left. So at this time here, I've actually expanded the pupil. And you can see that this part here, the capsule actually has run out. And I'm going to put the haptic in. And just here, there's really no capsule here. All right, the rexus has run out there. So once I put the haptic in, I've locked the optic into position. This lens is not going to go anywhere. So in this case, we managed to get away using the posterior capsule. So to fixate these lenses, you don't want the toric lens to shift, you don't want to shift out of the bag, right? You can really lock it in with the posterior capsule. So in the face of adversity, do not panic. The trifocal IOL must be centered perfectly, centered, preferably placed in the bag, but you can adjust for refractive error if it's placed anteriorly, in the case like in the posterior polar cataract, where there was a equatorial rip. IOLs with toric correction must be fixed in position and stable, so both anterior and posterior capsules can be used, and I showed you the case where I used the posterior capsule rexus. In that case, of course, the other way, if the posterior capsule gives way, you can anteriorize the optic and reverse the capture. But never place a single piece acrylic lens in the sulcus and it's not locked into place. Right? You may be able to use a premium IOL in the presence of a posterior capsule rupture and achieve optimal results. Thank you very much.
Can I ask a question, please?
Yeah,
Professor,
please.
that was a lovely surgery. I just wanted to know, what is the ring forceps that you are using to hold this thing? That looks very nice. I mean, can you give us a little more detail about it, please?
Thank you so much. It's called the Chi Micro Grasper IOL forceps. Initially, when I designed it, it was made under ASICO, which has now sold out to Katina Koza Katina. So you can get it there, and I have no financial interest. It comes in a 23 or a 25 gauge.
Oh, 25.
Yes.
Thank you very much.
Thank you.
Dr. Chi, great presentation. I was glad to see that you do a reverse optic capture or optic capture of these premium intraocular lenses. Unfortunately, these lenses don't come in a three-piece platform. I have also done that in a few cases where you have had a PCR to stabilize the lenses, depending on where the capsular support is there. But the classical teaching is that, and when I've shown these videos, others have objected to it. Classical teaching is that, in a single piece, you don't have any part in the sulcus. And what is your observation on the post-operative follow-up, inflammation, glaucoma, etc.? I usually keep these patients on steroid drops or NSAIDs for a longer period of time. And it has worked out. What has been your experience?
I don't think there is really a problem. In fact, I didn't show one video where this was even earlier, like 2006, where I was putting in the Restore Plus 4. And I used a Royal injector, which is a single push, and it shot through the posterior capsule. And since the lens was already in the bag, all I did was I just used the viscoelastic cannula, went under 1 inch, and I just lifted it up and optic captured. And I followed that patient up for years, and she had no complications because the vitreous does not come forward, right? I don't go do a vitrectomy because it doesn't present. You've just ruptured the capsule, and you've not disrupted the vitreous phase because you've not aspirated. So I don't think there's a real problem with that. Even with the chafing, of the iris, I haven't seen that.
I think with this Alcon lenses, they are a little softer and the capture is easier there. So if you have a little rigid designs like a Technis or other lenses, very difficult to get capture. Both the posterior capture or reverse anterior capture, both are difficult in those lenses. So if you're lucky that you have these soft lenses, you can do all these procedures. But you rightly pointed out, never put these single-piece lenses on the sulcus. That is bulky and they can cause what Dr. Ramurthy talking about. These haptics can also create inflammation, which is not visible sometimes, but they are continuously rubbing against the uveal tissue and can cause, uveitis and glaucoma, CME sometimes.
Yeah, so I've mainly used the Alcon lenses for this kind of a case because they're, very easy to maneuver. They're not so thick. If you need to cut it out, also it's much easier than the Technics platform. And also because these lenses have a thinner profile. So I think if I anteriorize the optic, I really don't worry about having chafing and UGH syndrome. Whereas the Technics platform is thicker. So you may run into problems with a smaller eye.
Absolutely, thank you. Now we have Professor Namrata Sharma. She's going to take us through the enhancement, post-surgical enhancement after premium IOLs, because we talked about, a little bit of a residual refractive error, little bit of cylinder remaining. These premium IOL patients are never happy. So these are patients, they demand it has to be corrected, it has to be solved. So we listen to Professor Namrata Sharma. She's going to take us through that.
Thank you, sir, and thank you for making me a part of this course. I would be talking to you about post-surgical enhancement after premium intraocular lens implantation. There might be some overlap because some of the problems may be there also in non-premium IOL implantation. There are no financial disclosures, and we have, as far as the IOLs are concerned, evolved and right from 1950 until now, where it continues to evolve. And it evolves mainly because our requirements have been changing over the past few years. But I think, like it has been emphasized earlier, the patient expectations is very important. Sometimes after these premium IOL implantation, even when the results are less than perfect, the patients may not be bothered by it, and sometimes they may be bothered by it when they may seek you. There are cases at risk where these residual problems may occur, and this can occur because of inaccurate biometry, especially post-LASIK or in high myopia or high preoperative astigmatism or pre-existing high-order abrasions which have been missed, or because of even ocular surface disorders, unrealistic patient expectations, or sometimes when there is a IOL tilt due to zonular dialysis or large capsular bag, or there are events such as trauma, etc. So decision to proceed with enhancement would depend. I think the most important thing is the level of satisfaction of the patient. So if the patient doesn't want it, then of course we don't do it. But also important is the fact that what are the potential benefits and risks of a second procedure, and obviously the most important for the patient point of view is additional cost of enhancement if there is any. Understanding the patient expectation is important, and also understanding the current situation vis-a-vis what can be promised. So the choice of procedures could be keratorefractive procedures, toric IOL rotation, piggyback IOLs, and sometimes even YAG capsulotomies for problems that have occurred. So keratorefractive procedures would include LASIK or PRK. First treatment for residual refractive error can be this. And high probability of success is there in achieving targeted refraction, provided the residual refractive errors are really not too much. Now the limbal relaxing incision or arcuate keratotomy was traditionally used earlier, which was nomogram guided, minimally used, but only thing is it doesn't have very high predictability. So more or less, as far as the premium IOL implantation is concerned, it is not used. The prerequisites for any enhancement that you would want to do is that the refractive error should be stable, the residual refractive error should be stable, and the topography should be normal. And in these cases which go for laser vision correction, the IOL exchange, if it is contraindicated, is generally contraindicated in these cases, and monovision adjustments are often not possible. So basically, if you want to do LASIK, and this is a study which showed that if you want to do LASIK for these patients, it does give good results where the creation of the flap is done by the femtosecond laser, elevation is done, application of the excimer laser on the stromal blade, and flap reposition with irrigation of the interface. People have even tried multifocal femto presby LASIK in pseudophakic eyes, but there are not very many studies of the same, although isolated reports which are available do show good results. This was a review article actually which looked at outcomes of excimer laser enhancements in pseudophakic patients with multifocal intraocular lenses, and it did show that in the studies that were available, the multifocal IOL is safe, effective, and it is laser vision correction is predictable. Of course, if there are problems like posterior capsular opacification, then that has to be dealt with the YAG capsulotomy. Now, at times there may be a problem of the rotation of the intraocular lens, especially if you use the toric intraocular lens, and we do have Aura. I think it is a great tool, especially when you have to see whether the axis is correct or not. And although it is now discontinued, but it does tell you, it does give you NRR, that means when no rotation is required. And this was a case which was referred to us, which was off-centered in fact, and on Aura we were able to center it. The patient didn't want a exchange of the lens because didn't want a surgery, so no exchange of the lens was done, only the axis was rotated in position. Then piggyback IOLs can also be done in cases of high residual refractive error, when there's a refractive surprise, when there are extremes of biometry, and they provide toric correction as well as multifocality addition. And this is a case in which the piggyback intraocular lens implantation was done a post-RK patient where there was a residual refractive error which was present. And in this, first the cataract surgery was done, and then subsequently, because of the residual refractive error that was there, post-op day 1, we had a surprise of plus 0.5, 5.5D in fact. So a piggyback IOL was placed on the IOL which was already there. Alternatively, we could have exchanged this IOL also, but in this a custom-made add-on piggyback lens Sulcoflex was implanted, and the post-op results following this piggyback IOL were acceptable and were optimal. And when the refractive error is high, that you actually have to customize it. And so the visual acuity on post-op day 1 itself was 6.6. Now, people have described polysodrophikia from piggyback to supplementary sulcus fixated IOLs, but I think this is taking it to the other extreme. And there are various IOLs which are present, which can be sulcus fixated supplementary IOLs, as has been shown from various companies. Rotational stability of the toric intraocular lens, like I said earlier, and this is again a meta-analysis which shows that toric IOLs of current era have exceptional stability with a mean rotation of only 2.36 degrees, and the materials and the methodology for making them is getting only better. Another problem could be of post-op dysphotopsia, and this Dr. Prakhyat Roop has described new device to treat this negative dysphotopsia, and this paper is again published. Apart from this, reverse optic capture can be done, or nasal optic truncation has been designed, or alternatively you can even change the position of the lens, and it can sit in the horizontal orientation rather than the vertical orientation, where it will cause less amount of dysphotopsia. Now this is the negative dysphotopsia ring which is being implanted. So basically in this the pupil is dilated first, and this is subsequently followed by the negative dysphotopsia ring. This comes by IOCare group, and the material is hydrophilic, and this is put into the injector folded like you would fold an intraocular lens, and then subsequently is implanted over the lens which had previously been implanted. And the idea is that it keeps the bag a little bit stretched, so the reflection of the rays which occurs from the edge of the lens is taken care of, and subsequently the irrigation aspiration of the viscoelastic is done. This has been done in more than 20 plus eyes with good results. Now, so to summarize, I think post-cataract surgery refractive error can be corrected by cornea-based procedures such as excimer laser, options of LASIK or PRK, or lens-based procedures where IOL exchange can be done, or piggyback IOLs can be used. But I think it is important that it should be matched with the patient expectations, and also we need to counsel these patients for the second procedure of enhancement that is done in these cases. And I think pre-op counseling for the second procedure, like in cases of post-RK eyes or in eyes where you expect that this might occur, is the point which is of utmost importance. Thank you very much for your kind attention.
Thank you, ma'am, for comprehensively covering all the enhancement procedures. I now invite Professor Jeevan S. Tityal for his talk on phacoemulsification in small pupil and implantation of premium IOLs.
Thank you, Dr. Manpreet. I just wanted to ask Dr. Ramamurthy, is there any Indian companies making these, piggyback lenses? Because otherwise very costly.
Yeah, I have been using the IOCare lenses, no financial interest, and they have the piggyback lenses for plus minus power cylinders as well as trifocals.
Any specific calculation way to calculate the IOL power in these cases?
It's simply based upon what is the residual power for every diopter of positive spherical power. That is, plus 1 means it's 1.5 diopters. If it's minus power, it's 1 diopter is 1 diopter of power. That is, minus 1 is minus 1. So if I have plus 2 diopters of spherical power to be corrected, it's a plus 3 piggyback that goes in.
I think that's a very important point. I wanted people to understand these lenses are also available and the calculation can be very simple. And instead of trying to exchange the lens, which they showed, which is totally 5 rows, which is damaged, especially where people have done a large yac-castlotomy, things can be very tough. If you can implant these piggyback lenses, things can be very, very simple. Thank you, Dr. Ramamurthy. I thought I'll show 1 or 2 videos because our dear friend Dr. Maligan could not come this time. So I'll show you 1 video on small pupil, how to manage these cases also. So this was 1 case. A young patient came for a toric IOL implantation and pupil was poorly dilating and had a significant cylinder for this patient also. So this was the dilatation on the table. Normally, I am a little, egoistic person. I thought I'll not use any device and complete the entire procedure without using the device also. So in these cases, I think pre-op use of NSAID is really helpful in maintaining the pressure. So this is what I'm doing. I'm injecting the adrenaline intracamerally under the viscoelastic cover. The pupil was very rigid. The rigid pupil is normally not floppy. So you can still do a good surgery. So I'm doing a rhexis, which is slightly larger than the pupil size. I thought this will be all right. At this stage, I realized I had forgotten that this was a toric IOL implantation. Do you all understand in small pupil surgery you might be able to complete, but putting the lens in proper axis can be really challenging in this situation. So at this stage, I thought let me expand the pupil so that my surgical area will be bigger. There are 2 ways to expand the pupil at this stage. One, you can go for intracameral devices like BHEX or Belligan rings, which can expand the pupil to a desired size of 5.5 millimeter. Other thing, to use iris hooks. I normally prefer iris hooks in cases where I've already initiated the surgery, where sometimes these devices can be difficult. Both can be put. And this is my technique of putting 6 iris hooks so that you have a nice expansion of pupil and making these incisions little posterior to limbus. You can see the bleed has come. So if you're little posterior to incision, your iris hooks will be parallel to the iris plane and it will not tend the iris so that you have less damage to your sphincter in these cases also. And that is a small tip I want to give to all young people sitting here. Make sure that you have little posterior, and these are 6 incisions. 1 is classically sub-incisional. Then I'll put all the 6 inside, then 1 by 1 slowly expand the pupil rather than just expanding to one side at one go. This is how, because this is a rigid pupil, you can tear much more. Now you can see nice 6 hexagonal appearance, re-stain the anterior capsule. You can see my rhexis was hardly 3 millimeters. So I'm trying to enlarge the rhexis. So this gives the opportunity to do the rhexis in a proper manner so that it gives you a better emulsification space for your case. This is a micro faucet, vitreoretinal island peeling faucet we normally use for doing these procedures. Do a good hydro procedure. Rotate the nucleus, because in small pupil, sometimes nucleotomy becomes easier, but removing the epicortex becomes very difficult because leave a large epicortex in these cases. So first I take out all the loose cortex, make a little trench. This is a grade 3 to grade 4 nucleus. Once you have this trench, you have now a good hold of nucleus. You can chop it better now. Rotate. See, the rotation is still not possible because I could not do a good dissection here. I'm taking out one more chunk from here. Once I've taken this chunk, the nucleus will be free now. You can see the nucleus has got free. This is called internal hydrodelineation has happened, which has separated the core from the epinucleus. Now you can one by one chop and take it out, the entire nucleus now. The learning here is little trench so that better hold deeper and you can chop it. And this is a technique which described by our colleague Dr. Tushar. This is called a hybrid technique. So this is a phaco handpiece inside only. Without compromising the interchamber dynamics, we just detach the aspiration tubing, attach to aspiration cannula of bimanual. So in that way, you can aspirate all around now. So I'm aspirating, this is called a hybrid technique. You can see that the rexis is still 4 millimeter. So I'm injecting the viscoelastic here. This is the Alcon toric lens, which is being implanted here. And this is a trick I normally do in some cases, especially cases with pseudo-exfoliation. This is slightly smaller rexis. I make a multiple nicks in the anterior capsule. You can see this V-shaped nicks. This will enlarge the rexis size and also decrease the phimosis if it has to happen in a post-op period also. So this is a good technique I have used in a pediatric patient, which I published long time back. This we call it a postage stamp capsulotomy. Then I remove the viscoelastic from behind. I think this is a trick which you need to know. Whenever you use the hooks or a device, you require a space to be maintained. So if you remove all the viscoelastic, later it has become very difficult to take out these hooks also. So what I'll do, I'll remove the viscoelastic from underneath the intraocular lens so that the lens can be placed accurately. I'll remove the viscoelastic from underneath. Now I'll place the lens at the desired axis. Now inject the viscoelastic over the lens. There's no viscoelastic underneath the bag here. Then comfortably remove all the hooks. Now only what you have to do is you have to remove the viscoelastic from anterior side. The lens will be stable. So this is how your lens is going to remain. If you remove the hooks before, then remove the viscoelastic, the pupil constricts and entire management of toric IOL becomes very difficult. The learning here is you always remove the viscoelastic, align the IOL under the viscoelastic, inject OBD over the IOL now, once you remove from underneath, then remove the hooks. In that way, you are at least going to damage the pupillary margin and your lens will be in the bag always. And this 6 hooks gives you a very nice orientation of a pupil. Sometimes if you only 4 hooks, then you stretch too much and that is not a good idea in these rigid pupils. Second case which I want to show you is a case with post-radial keratotomies. Many of us always debate, should we put toric IOL or not? Should we inject multifocal IOL on that? It's based on a biometry. If you see here, that it has a corneal astigmatism minus 2.3 diopters, which you can see a large degree of error is there in this particular case. It has almost 8 incisions. There it is better to map your cornea, look for aberration profile. If you see here, this is a corneal aberration profile. This is astigmatism. Trefoil coma is very, very minimal. No trefoil, no coma. And this is very nice MTF values. And this patient, cornea is good. If cornea is good, you can always take a premium IOL as an option for these patients, and surgery can be effectively done. One of the best formula which I have realized in our post-LASIK patients, a post-RK patient, Barrett's 2K formula, which gives you a nice calculation. Always make sure your incision is little posterior. You can see, so that you don't disrupt the incision which are reaching or approaching up the limbus area. These RK incision, what we should do in the 90s, they can be 80s, it can be very, very deep, almost 90-95%. And if incision is purely corneal, that will definitely open up during your surgery here. You can see it is almost 0.5 millimeter posterior side, and my site incision is also little posterior, and that is important. And Again, we will do our axis image guided so that you have a proper axis, because these AC depth may be little more and your axis size can be little altered if you even mark on the corner side also. So this image guided system gives a nice orientation. This is the hydro delineation and hydro dissection being done, mainly hydro dissection here. Rotate the nucleus. Though the pupil little floppy, but it's well dilated. And again here, this is my routine approach. Make a little trench so that you have a better hold of nucleus. Then subsequently chop the nucleus in 2 halves. Then make it a multiple chops and take out the nucleus subsequently in the bag and take out cortex aspiration, epicortical cushion and cortex aspiration very comfortably. The antechamber dynamics may be a little different in high myopic patients. Make sure you have a good IOP control if you are using active centric, or you always look your parameters will be moderate in these patients also. So once we remove the entire cortical fibers, maintain the anterior chamber, use the intraocular lens of desired calculation. This is a hydrophobic toric IOL from Technis 2 design, which is being placed in our axis of reside area. The only thing which I want to show here, surgery is simple, but again, remove the viscoelastic from all areas. Make sure that you put a suture in the main wound. Don't try to hide it too much, otherwise wound gets split. So this is one teaching in a post-RK patient where incisions are very close and they're very long. Always try to suture the main wound so that you don't disrupt the wound, or even don't split the wound. That will cause induction of a new astigmatism and things can be very difficult. So this suture can be removed after a week or 10 days and patient visual acuity will be better. This is a day 1, patient did very well, post-RK patient. So here what I talk about is doing incision little posteriorly, maybe a scleral tunnel sometimes. If you are sitting superiorly with more than 12 incision, it is better ideas. Never overfill the anterior chamber. RK incision can open up. Suture the main incision after your surgery, which is a very important point for all of us to understand. Sometimes I have seen a post-RK patient, especially if you have more than 12 or 16 incision, there can be diurnal variation in a corneal profile. So it is better to see your patient before jumping on the surgery, at least in a 1 or 2 episode. That means patient coming today, I might see after 1 week or 15 days and different timings of a day. If patient come 9 o'clock, I might see patient towards the afternoon, so that I know that there is no variation in the corneal parameters. If there is a variation, that cornea is very, very weak. So sometimes that may make a huge difference in your IOL power calculation and patient may not be happy subsequently also. I remember one of case referred to me, the patient used to have almost emotropia in the morning time. By the end of evening, used to have 4 diopter error in those cases because of the cornea becoming so weak. Ultimately, I had to took that patient for cross-linking subsequently. This is one case I want to show to you that things can go wrong anytime. This is a femtosecond laser. This patient has undergone trifocal toric lens in other eye. This is second I am operating under femtosecond laser assisted, very nice capsulotomy being done. The nucleus is being fragmented as per the chop pattern which was there in this particular nucleus. Remove the nucleus effectively within the bag now. The surgery becomes very simple once you have femtosecond laser because you have a nicely oriented capsulotomy. Also nucleus fragmentation and chop pattern, this is a Lensex platform, can be done effectively now. Aspiration of this cortex can be tough sometimes. Therefore, I am doing again, this is a hybrid technique of taking out the cortex, because once cortex are cut with the laser, sometimes aspiration difficult. Bimanual aspirations are definitely easier in these cases also. This is sub-incision can be difficult to remove. I left the fibers here. I'll be injecting trifocal toric lens in this patient, which is simply effectively going inside now. Once I've implanted, now I thought I'll do a viscoelastic removal and remove this chunk of cortex. While pulling this, I realized I've torn the capsule here. You can see this is the area of torn capsule, which is quite big. You see here, it's a very big torn thing. So I'm injecting dispersive viscoelastic underneath the IOL to tamponade this vitreous face, which I'll do from either side also. So this will retain the vitreous face in a proper position. The idea here is to now I can't maintain this lens in the back because large tear is there in the superior side. I thought the only way better would be to have a reverse capture to be done in this patient. And this is a technique which is simpler, you can understand if you do a bimanual technique. If you see here, I'll inject dispersive from this side and I'll take another cannula from this side, and this will lift the optics over the capsulotomy side, which is normally 4.9 millimeter for me, and maintain the haptic behind the capsulotomy. So you can see this will have a square shape now, and that is the end of surgery. You can see this is square shape, this is underneath, and this is over the rexis, and almost matching my, the concerned area of dots here. So in that way, you can safeguard. So lucky I was that it happened towards the, end of my surgery. No vitreous was, prolapsed, and lens could be captured very effectively. So this is the orientation here, and actually did very well subsequently also. This is at 1 week, the picture here, nicely captured, 6/6 vision, eye was stable in this case also. But when this patient came to me after 1 month, the patient was not very happy. She was telling me, I could see better day 1, but I'm not seeing very well after 1 month. Doctor, what is the cause? So I thought maybe some sort of inflammation would have caused, some retinal pathology. The OCT scan macula was absolutely clear, but there was induction of 0.5 diopter myopia because lens we have captured anteriorly. So there a little bit of myopic shift happens, and that needs to be explained to patient. If it would have happened before you implanted the IOL, you could have managed this, by changing the lens. But once it is inside, you have to manage like this only. Third, the last video I'd like to show you is a very hard cataract. Sometimes we are worried that hard cataracts, you may not achieve the good surgery, and implantation can be difficult also. So this is a technique which I have used. This is I think she was almost 85-year-old lady with a hypermature stage. Entire cortex had got, almost in a fibrosis stage, but rexis could be completed very effectively. You can see now even a hydro procedure are difficult because this is the entire cortex which has become thick fibrous mass here. And I'm going to use a technique of pre-chop here so that nucleus chopping can be easier. This is called a mild loop, which I'm inserting from one side, open inside the capsular bag. So once you have a complete opening, you have to rotate your hand so that this loop gets in the central part of the nucleus. Stabilize the nucleus with your second hand, then close the loop, and this will cut the nucleus into 2 halves. You can see, I'll take out now, it cuts the nucleus 2 halves. Now I'll rotate the nucleus 180 degrees. Again open the loop so that it goes underneath the capsular rexis margin, opens inside the bag. So in this way you can make 4 chops of the nucleus very effectively. And now I have broken the nucleus, this hard nucleus, into 4 pieces. The central backbone has been cut or broken by this my loop here. Surgery becomes very effectively simple. I'm using the dispersive viscoelastic to tamponade as well as safeguard the endothelium. Further, I can chop now. I've chopped into another 2 pieces. This 4 will become 8 chops now, and effectively I can emulsify subsequently. You can make it further smaller chops also. So this very, very hard cataract can be simply emulsified now because the central attachment has been broken. In hard cataracts, the major difficulty is difficult to break the central area. Despite making a deep trench, sometimes very difficult. Cracking becomes difficult, chopping becomes difficult. So this simple addition of using pre-chop techniques can decrease the time of emulsification, the energy, and effectively less damage to other structures of intraocular structure like corneal endothelium, wound burn, everything can be decreased now. The entire thing is taken out. There no cortex is there in this patient. Now I'm implanting the toric IOL, which will replace at desired axis also. So you have various challenging situations which can be managed very effectively if you have the good idea of what is happening, what can happen next, and how to prevent those things, and implanting becomes simpler in these cases also. I would like to thank you all. You can go through our, this is the review article we had published in IGO, where it gives you all the intricacy of toric implantation. And any questions we'd like to answer. The panel is still sitting here. Thank you very much for a kind listening.
Sir, this pre-chop is available, it is made by which company, sir? No.
The story goes, this technique was first, described by Disa group of people.
Sir.
Arup Bhaumik, he used to call it a snare technique. And it was a totally indigenous made the wire.
Sir.
It was a platinum wire. You could just, take it inside and pull it and used to cut. Now it is commercially prepared by Jai's group of people. So
Jai's.
Jai's is manufacturing this and they supplied this. And initially, with one loop, you could do multiple surgeries. You could autoclave them also.
Sir.
Now you can do only, I think, four cuts.
Yeah.
And it costs around 10,000 rupees. Yeah. So it has become commercial, which was actually, devised by one of the colleagues from India only.
So it is so
In fact,
sharp.
that video got a Best of Show award in American Academy and AACRS.
So it's so sharp, it cuts such a hard, great type cataract.
Yeah, it's cut like a knife.
Oh,
Very
nice.
sharp cut.
Very nice, sir. Thank you.
Only thing I like to highlight here, your capsular bag has to be intact.
Sir.
Your rexus has to be intact.
Right.
And the size should be around 5 millimeter plus.
Yeah, we have to do a little larger, bigger.
If you have a very small rexus, you have a difficulty.
Right.
If you have the bag which is damaged, it's difficult. That means posterior polar cataract, you should not use it.
Right.
That's the only contraindication. Otherwise, people have used this in a subluxury cases also. You could still do it.
Right. Excellent, sir.
Yeah.
Thank you, sir. Thank you.
Sir,
Yes, please.
sir, I have a question. If you get an eccentric rexis or a larger rexis, should you continue with the toric IOL?
There is no harm if patient has a significant toric to begin with. Suppose I have a patient who has 1.5 or 2.5 cylinder. That amount of cylinder can be easily be corrected by this lens. Eccentric rexis is a challenge. I can understand. The only thing what Dr. Ramamurthy also asked this question: if you have a torn rexis, what next? We tend to forget this patient. I normally see all patients where my rexis are compromised. I put the IOL inside. Look for how this bag behaves post-operatively. Because if your bag is eccentric, one area will be covered onto the IOL surface, other area will be open. So there's a jipping phenomena happening in the post-op period, and lens can shift at that time. To avoid that phenomena, if there's fibrosis happening, there's a little bit of shift. If you do a YAG laser cuts in the anterior capsule where fibrosis is happening, the area which is covered onto the IOL surface, subsequent decentration will be avoided. The idea is to see post-op carefully, maybe after 1 month, 3 months, 6 months, 1 year, what happens to these lenses.
Sir, I have a question, sir.
Yes.
Hi. Actually, the question is not to you, it's to Dr. Chi.
Thank you very much.
Ma'am, in one of your videos, you have shown that in a PC dehiscence, say posterior polar cataract, you have rotated the toric IOL. So, is it possible, or could you teach us more? Bimanually, you have rotated to the desired axis.
Okay, so what I was trying to highlight is that the lens is first implanted into a viscoelastic filled anterior chamber. So it sits on the iris.
Okay.
So you then rotate it in the anterior chamber to the desired axis, and then
Tuck
you
the-
drop the haptics into the bag.
So, you are preferably, rotating or dialing the IOL over the iris,
Yes,
keeping it in the axis and then tucking the haptics.
exactly.
But you are not rotating inside the bag.
Correct.
Thanks.
Thank you.
Excuse me, question. Young patient, around 15 to 16-year-old, one-eyed cataract and other eye is normal. Which lens should we, multifocal or adopt or monofocal?
I think you can ask the patient for his choice Obviously, multifocal requires counseling depending on does he drive at night, will glare and photopsia be an issue. Otherwise, you can go for a multifocal intraocular lens because the other eye is normal young patient, not yet in the presbyopic age group, if that's what you mean by young. Then implanting a multifocal intraocular lens will help him remain spectacle independent for near.
I think, sorry Manpreet, we always, well, your question is valid. One eye has a cataract, one eye has no cataract. The situation is, a patient has a good visual potential because these cases can have poor visual potential also. Let's consider this patient has a good visual potential. We are looking for a binocularity. We are looking for binocular function. I'm not worried about which lens I'm going to put in this patient. Suppose I put a monofocal lens for this patient. Without any distortion of optics, he gets a 6.5 vision for distance. He'll be very happy because his distance vision is majorly required for the young age, and he'll be quite comfortable. Near he can still manage because his other eye is accommodating. So he'll never have a difficulty. I can understand multifocal lenses might give you advantage of intermediate near vision, which is not concern in this young patient because his other eye is going to support everything. So my concern will be to give a very clear distance vision for this young person, which is the requirement.
Okay. Thank you, sir.
Can I comment?
Yeah, sure.
Yeah.
Most welcome.
So I had a 9-year-old child who was referred because his vision was hand movements, and he was found to have a persistent fetal artery with an associated cataract and possible defect even of the posterior capsule. So obviously he might be a little amblyopic because the cataract was not really commensurate with that hand movement vision. But what I did was I actually implanted a pure C toric lens. Okay. And explaining that yes, your son is amblyopic, but once we clear the visual axis, we'll see what his visual potential is, and there's really nothing to lose when we use a EDOF lens today, because even if he becomes more myopic, that EDOF lens still gives you depth, and you can still correct that refractive error with glasses. I mean, when you implant a child, we're always worried that the refractive target will keep changing because they may become myopic with a intraocular lens. But that child actually, amazingly, post-op, he was like 624, and then he continued to improve because this is the first time he's seeing well with that eye. And even without patching, he reached 612, and that was like 1 month after surgery. Okay. So I prefer EDOF lenses, and I correct the astigmatism.
Accepted, correction of astigmatism is paramount in any case because that may be cause for amblyopia sometimes. And astigmatism has to be taken into consideration. But people sitting here, if you can give some patient a clear distance vision, whatever you do it, that patient is going to be happy. I give a multifocal to patient, I give an EDOF patient. If he doesn't see well for distance, he or she will be never happy. So that's the first priority. Therefore, the IOL power calculation for these premium IOLs are very, very important to hit the target. If you miss it, then all those, we had two, presentation, how to manage post-op in these patients. That's a very difficult scenario. If I have to do PRK onto the cornea after making pseudophakic, I have to do a LASIK or smile on a pseudophakic eye, the results are never going to be as good as a virgin corneas. Similarly, if I have to put a piggyback lenses, I'm putting another lens, bulky, the space is less, I don't know what is going to happen. The primary aim for these cases is do a good biometry, which Dr. Manpreet talked about. In a virgin cornea, do a good biometry, take an optical biometer, that's going to safeguard your this thing. And have your own A constant. Do a multiple cases, you realize what is my error. That should be compensated.
Okay, sir. Thank you very much.
Okay.
Thank you very much.
Yeah, you have, okay.
You're not audible, sir. You'll have to come.
Mike, please, Mike Udarala. Yes.
I think, small question for details, sir. The snare you have shown, or pre-chop, it is slightly different from what they had made in Disha. They used to do it in the anterior segment, but you did it in the bag itself. The breaking of the nucleus part, you have done it in the bag itself.
Yes, yes. Because this is much more well designed and titrated.
Yeah.
Because they had used, initially it is for a SICS surgeries.
Right, sir.
Where they could make it into two halves and
Right.
take the nucleus out through a smaller incisions.
Right, right.
But this is translated better now to use in a various case.
But how comfortable or safe is it in handling?
I think once you use it in a few more cases, you become very effective and very simple. Initially, you might struggle in one or two cases because it doesn't go properly inside the capsulexis margin, doesn't open comfortably, rotation becomes difficult. And I did not understand first, I have to stabilize the nucleus before I pull this. So once I could realize I have to put my Sinski hook to stabilize the nucleus to have a counter force, it was very effective, very simple.
Thank you, sir.
Thank you so much. Okay, we'd like to thank all of you for making this session so lively. I'd like to thank my friend and my guest, Professor Chi, coming all the way from Singapore, though she is half Indian. Yesterday she was Punjabi, she was in a Punjabi dress, playing kabaddi. And my colleague, Dr. Namanpreet Kaur, Dr. Ramamurthy, for last-minute addition to our instruction course because Dr. Boris could not make it. Again, thank you all of you for giving us this encouragement to do such a big event in this city of Delhi. Thank you, and welcome to all of you next year in Jaipur, where I am to take over as a president. Be there. Okay.